Let me thank all of you for being here and just say to Vive Healthcare, I want to thank Vive. Is anyone here from Vive for supporting this panel and also for supporting the CBC Foundation and really for being an unbelievably steadfast partner in this in our battle against this epidemic. And also, I want to say to Phil, thank you so much for being here and being the moderator for this panel and for your tremendous, consistent leadership, because what you have done and how you have stayed on the battlefront, and this is a war, really, that we're in, has just been amazing. You have educated so many people and so many members of Congress and so many of us on why we need to fight for an AIDS-free generation and that we can achieve it by 2030. So thank you very much, Phil. And also, let me just say to all the panelists how important it is for you to be here. We began this, what, how many years ago? 10 years ago, maybe 12, 15, 18, I don't know. It's been a while. But it's important that we have this panel discussion here at the CBC Foundation because we're building a movement, and right now with this Trump administration trying to take us back, now more than ever must we fight to say in no way are we going back, but we're going forward. You know, we saw that this appropriations bill, the Minority AIDS Initiative, was just zeroed out on the House side. We tried to restore it, couldn't do it, but I think we'll be okay in the Senate, I hope, if we do our work. But we must be vigilant, and as we stay in California, you must stay woke, and you're helping us to stay woke. I was at the United Nations. I'm the UN rep for the Democrats from the House of Representatives, and I'm telling you, everywhere that I went, people from all over the world thanked all of us just on the international front for PEPFAR and for the Global Fund and for what we have done just on an international basis. And we've really gone from now, 50,000 people being on antiretroviral treatment and to 17 million? That's the number. Life-saving therapy. I mean, that's amazing, and we couldn't have done it without you. And so just know that as I move around the world and in my own community and throughout the United States, people recognize the importance of your work here and of the progress we've made, but they're also worried about it becoming stagnant now and going backwards. And so thank you. When you go home next week, remind people of the impact of this new Graham-Cassidy horrible repeal bill. Urge them to do the work with their senators and make sure they call them, email them, put that street heat on so that we can defeat this new repeal bill, because it will tremendously impact HIV and AIDS initiatives and care and treatment and everything that we have fought so hard for in our healthcare system. And so just know that that's the charge I'm giving everyone. And I think all of us are talking about the importance of next week and going home and staying vigilant, engaged, and staying woke. So thank you again, Phil, very much. Phil's going to moderate the panel, and he always does the heavy lifting, and I get a chance to listen. Thank you, all of you.
So can we give another hand to Congresswoman Barbara Lee? So let me say that, no, first of all, as we all know, your leadership, Congresswoman, has been exceptional. And the fact that you are there on the front lines and in the belly of the beast these days, standing and defending us and saying, no, not under your watch, is so important. And that wherever we turn, you are there, and you're beside us and in front of us and behind us. Wherever we need you to be, you are there. And so thank you for that. I had prepared some opening comments, but I think I'm not going to use them since we kind of are a family here. I can't imagine that there's anything that I would say that most of you don't already know. And today we want to, instead of doing kind of a talking heads format, we actually want to do a conversation. And so we put together two panels. The first part of the program today is really a conversation with our panelists. We have one panel that's going to talk about some of the challenges addressing the domestic fight against HIV and AIDS, particularly the attacks on the Affordable Care Act and efforts to repeal the Affordable Care Act, and the possibilities of actually stripping away health care from some 20 to 25 million Americans, and what impact does that have on our efforts to fight HIV. We will follow that with a panel where we kind of expand the conversation to the global epidemic, and what role do black folks in the United States, particularly black folks who are engaged in faith issues, have played in that effort and might play in the efforts in the future. All of these against a backdrop of our current administration. So I will include some stats related, as we begin, related to some of the things we've seen in the Affordable Care Act. Really, when the Affordable Care Act was passed, it brought health coverage to millions of Americans who have been shut out. There's no community actually in the United States that has benefited more from the Affordable Care Act than black communities, and therefore no community that stands to lose more than black communities. Before the ACA was passed, there were 26% of black Americans were uninsured, compared to 16% of white Americans. Today, only 15% of black Americans lack health insurance. Now, that kind of movement has not happened in any other community. Now, that's interesting because black America, we have not traditionally been early adapters. Now, that has not been where we've led. But when it comes to accessing health care and using the Affordable Care Act to get there, we actually have been among the leaders in utilizing that. There are more than 2 million black Americans who lack health coverage, that lacked health coverage then, who have it now. That's a tremendous gain. And some of the attacks that are happening on the Affordable Care Act, even though the Republican-led Congress and the White House have not yet succeeded in a repealing of the Affordable Care Act, they have done tremendous damage, and we need to be clear about that. Regardless of what may or may not happen legislatively, there are opportunities to undermine access for health care for poor people, for black people, for older people, for people who have chronic illnesses. All of those of us who are most vulnerable, and we need to really pay attention to that. At the same time, as we have had conversations about the possibility of ending the AIDS epidemic, and particularly conversations about ending the AIDS epidemic in the United States, we need to be ever vigilant that we can't end the AIDS epidemic here unless we're ending the epidemic everywhere. And so our focus needs to not only include our borders, but also outside our borders, And as Martin Luther King says, none of us are free unless all of us are free, and none of us are free of risk unless all of us are free at risk. And HIV has no respect of person or borders. And so that's what we're going to talk about today. I was going to introduce all of our panels, and I came prepared with bios on everyone. But what I like to do instead is very, very briefly have each panelist introduce themselves with a fun fact about yourself. Everyone actually has your formal bio, so a fun fact about yourself. But before we do that, we certainly want to introduce the head of the CBC Health Brain Trust. Representative Robin Kelly has entered the room. We'd like to invite her to. There you are. I just saw her. I just saw you.
Good afternoon, everyone. I'll just be really, really brief because I'm running from one thing to another, but I am the chair of the CBC Health Brain Trust, and this is a topic that is very near and dear to my heart. My best friend's brother died of AIDS, and it was a long time ago before all of the innovations and things were done. And actually, she married somebody whose sister died of AIDS also. They died for two different reasons they got it in two different ways. So it's really, really important to me what comes out of this symposium, what suggestions you guys have. We are legislators, and everybody's not Barbara Lee. We don't know everything, and like Barb, who's my mentor, and but we're looking for answers and suggestions and things that you think that we can do. We want to know on the ground suggestions that we can carry out and we can hopefully put in policy or carry out in our respective cities. But thank you so much for being here. I hope you're enjoying the conference. I know it's so many things being thrown at you at once, but you could do it. And just thank you, and thank you for everything you're doing and for helping the most wonderful Congresswoman in the world. So thank you guys so much.
And as someone who's originally from the south side of Chicago, thank you for representing my mom and my family there. So thank you for all that you do. So we're gonna, the idea is we're gonna have each of you do a fun fact. We're gonna spend about 20 minutes talking amongst ourselves, and then we're gonna do a transition. Freudian slip there. We'll do a transition, and then we'll bring the second panel up, and then we'll open it up for full-on conversation with all of us on both the domestic and the global conversation, if that's acceptable for folks. We also have postcards or index cards that are going to be circulating. So if you want to write your questions as they happen, since we're going to actually open it up at the end so you don't forget. So in real time, you can write your questions and we'll bring them up to make sure that all of those questions are addressed. Kiefer, who's going to be, you're going to be collecting or someone else? So Kiefer is handing them out as you come in the door, and she will collect them as well. Now, so why don't we start to my near right? We have Gabe Maldonado, and so Gabe, what's a fun fact about you?
So a lot of people don't know. I don't think people would expect me to be highly athletic, but I've been a snowboarder for 6 years. So
That's a fun fact.
yeah.
Miss Linda Scruggs.
Fun fact that many folks don't know about me would be I'm an ordained minister with a certification in sexology.
That's the combination you want to have. That's a good combination. That's the combination you want to have.
Fun fact. Well, a lot of people don't know that I'm a master carpenter, and I can build just about anything you would want. How's that for a fun fact?
I have a list.
Okay.
Good afternoon. So a fun fact about me is that I'm recently married. My husband is here.
Congratulations.
Wave, babe. About 11 months, almost a year.
Oh, fantastic.
Congratulations.
I'm Jesse Milan, and I just hosted my family reunion and made my great-grandmother's recipe for 1, 2, 3, 4 cake.
There we go. So we'll have to figure out what 1, 2, 3, 4 cake is.
Samples.
1 pound of butter, 2 cups of flour, 3 cups of sugar.
3 cups of sugar?
3 eggs.
Okay. Great. So, my first question is, kind of like Freddy Krueger, the efforts to kill the Affordable Care Act just won't die. So my first question, and anyone can start with this question, in your opinion and in the area of which you work, what is the area that has been most beneficial with the expanded access to health care that's been brought about by the Affordable Care Act over the last 7 years? Anyone wants to start?
I think what's been most beneficial from the Affordable Care Act over the last 7 years is really where Phil started the conversation about the number of people who are now covered with health insurance, but particularly for people living with HIV. And so when we look at the glass, we know that we are only halfway there, but for the states that have expanded Medicaid, this is a huge, huge win for people living with HIV. And the impact of it has not only made it possible for people to have insurance, but for people to get medications and to have doctor's appointments and to have viral load tests and CD4 count tests. These are really important. But unfortunately, we still have too many people who are not yet covered. And when we look at that map of the states that have not expanded Medicaid, we know where our work has to be done, and that's primarily in the South.
Interesting enough, in the Graham-Cassidy bill, the states who have expanded Medicaid stand to lose the most by the new bill. In fact, states who expanded Medicaid stand to actually be punished for actually making the brave choice to extend health care to their citizens. Who wants to go next? Gabe.
So my organization, True Evolution, is a Ryan White service provider in Southern California. And so as a service provider, one of the primary goals that we have, particularly as a minority AIDS-funded initiative, is treatment adherence and viral suppression. That's a big thing in my organization, is that our clients who come in, whether we're coming in for HOPWA services, whether they're coming in for psychosocial services or one-to-one counseling, that achieving viral suppression is a part of the work that we do. Now, one of the challenges that we had prior to the expansion of the Affordable Care Act was that a lot of our clients, particularly those that were caught in net migration, moving from maybe San Francisco or Los Angeles or Atlanta or Texas, moving into our region, there was kind of a disruption in their services for a period of time because it was difficult to figure out what kind of coverage we're going to get them on. And Ryan White only covered for the first 30 days, and ADAP, sometimes we can get it extended to like about 90. But essentially, having the Affordable Care Act allowed a lot of our clients to move swiftly into ongoing healthcare coverage. And what I have found is that when our clients, particularly our youth, because we focus on the 14 to 25 age, when they are plugged into a primary care provider with ongoing, insurance coverage, having a primary care provider, the chances of them contracting HIV, or if they're already HIV positive, developing co-infections, was significantly less. And that their health outcome was greater if they were in ongoing, continuous care. And that sometimes can be disrupted, as that we're afraid of if the Affordable Care Act were to be repealed.
Linda?
Can you repeat the question again?
What do you think is from where you sit, so maybe as a black woman living with HIV, what do you think is the most important advances as a result of the Affordable Care Act?
Well, not just me as a black woman diagnosed with HIV. I think that we think about the thousands of individuals that are diagnosed with HIV within states that had expansion. I think just as Gabe said, that they now have access to treatment, ongoing, consistent treatment, and not necessarily that rotating door of access. And because of that, we do see viral suppression. We do see people definitely living the quality of life. When we started utilizing the word quality of life in the 90s, we see that now when we're talking about treatment, when we're talking about adherence, even more so ongoingly.
And so someone working in a state health department, I think there are a couple things. The Prevention and Public Health Fund is one, and that's important to people working in state health departments because of the funds that go to laboratories, which provide the processing for HIV tests and even hepatitis tests. And in addition to that, as we see states like Indiana, who deal with outbreaks, who has dealt with an outbreak a few years ago, allowing us to do molecular surveillance and do those tests, the tests that allow us to see networks among people so that we can then begin to address outbreaks. And as my colleagues have mentioned around Medicaid expansion, that's also an important piece of ACA. We've seen in 2012 how Medicaid expansion helped 36% of the people, and then increased in 2014 to 42% of people who are living with HIV. So those are just two of the things that ACA has done.
And I would just echo the point that was made earlier about, for the first time, many individuals who were diagnosed with HIV would have access to care. And And as you probably know, many of you know, up until a while ago, African Americans, when they came into care, came in late to care, so their disease was at a late stage. So I think that is very important that we don't lose the ability to offer treatment to individuals, because it also is an impediment to getting tested if there's not going to be care available to you. Right. And that's also another very, very important aspect of this.
I'd like to stay with you, Dr. Hilbert, for a second. Now, as someone who works with young people and on a historically black college campus, what do you think, how does the ACA impact your students?
Well, my students are all, Meharry Medical College is one of the 4 historically black medical schools in the United States. You know, there are four sister institutions, Meharry, Morehouse, Drew, and Howard. And we have medical students, dental students, and PhD students and master's students. And there's about 850 of them altogether. So our students have a heightened awareness of HIV and the challenges presented by it just because of the nature of our campus. We have a lot of interactions with undergraduate campuses, and one of the biggest challenges I see is having the appropriate message delivered in the appropriate way by the appropriate messenger, right? And I think there were some resources provided ancillary to ACA that allowed us to do that better. And so one of the things we have to protect is the ability to do prevention work. And I think that's very important. That may not be answering your question, but that's the perspective I have from that point of view. And I also think that some of our campuses have not done a good enough job of promoting HIV awareness. They seem to be almost in denial, in my opinion.
Dr. McGuire, I see you chomping at the bit, so I'll go back to you.
Yeah, I think another piece is allowing students or people in that college age range to stay on their parents' health insurance is another piece. And I'm a graduate of 2 HBCUs, and
Well, do a shout out.
Spelman College,
There you go.
and then Morehouse School of Medicine, the Satcher Health Leadership Institute. So yes, I think it's important that we talk about HIV and not try to hide from it. We've got to address it, as well as the intersections dealing with sexual identity, sexual orientation, and getting people tested and not being stigmatizing certain populations on our HBCU campuses.
Jesse, sounds like you wanted to augment that, and then I see Linda has a thought.
I think for the HIV community, we can't forget that the prohibition of insurance companies discriminating against you because of a pre-existing condition has been hugely important for the HIV community, because otherwise, not only if you tried to get insurance, you couldn't get it, but no one could take you off it because of it. And I think that we need to remember that that's at risk here as well, and that this new Graham-Cassidy bill gives the states some options that can really, really start chipping away at that, if not eliminating it on a statewide basis. That is enormously important for us, particularly living with HIV.
Linda.
Yeah, I just wanted to add, and I know this is probably really down in the spectrum, but I think when I think about young people, many young people that we work with are not on HBCU colleges. They're not on campuses. Many of them have been separated from their homes and their communities, and they're surviving. And I think what the Affordable Care Act for them have even developed a new level at the workforce level of who's talking to them, and that they're right, that their peers are engaging them around healthcare. What does healthcare mean? They're in clubs and they're in the neighborhoods and they're under bridges surviving. So I want to make sure that we're knowing that ACA have gone under the bridges and they've sent other young people into these very desolate places to invite healthcare as a part of living, a part of survival, and being well with HIV or without HIV. So I also want to make sure that we know that when we talk about HIV among young, particularly Black communities, we're talking about underserved communities. We're not talking about the upper class or middle class young people. We're really talking about folks whose parents have not allowed them to stay on their health insurance, or individuals who separated from their health insurance because of the issues of stigmas and disclosure and fear of stigma items.
And I think that, Linda, you raised an important point, and I want to make sure rather than assuming that people understood what you're referring to around under bridges. Is basically the point that the ACA actually provides coverage for the most vulnerable among us. So people who are homeless, people who are disenfranchised in so many ways, young people who have been kicked out of their homes, people who live under the bridges. So that when you're talking literal. It's not it's not a metaphor.
That's
And I think that's important for folks to understand. That's the level of care that we're talking about. On that note, I think that Linda, you raised it, and I think also Dr. McGoy raised it, and that is the issue around stigma. Earlier, I was listening in on a conversation that Gloria and Marcia, who's going to be on our next panel, was talking about, quite frankly, the lack of science and treatment and HIV basic knowledge in communities. Now, and what role can has the ACA played in your opinion, or what work is left to be done around raising awareness in our communities around resources that are available? I know that I've had a number of experiences where I would have a conversation with someone about the ACA, and there's a few things. Number one, they not know that the ACA and the Affordable Care Act and the Obamacare are the same, that they don't understand the relationship with Medicaid expansion and the Affordable Care Act. Or when you talk about this new health insurance card, for many people, for the first time in their lives, they've had an opportunity for primary care. Their perception around that coverage is that now I have a card to show when I go to the emergency room. Because the notion of seeking care outside of the emergency room is a foreign notion. Now, and these are some of the challenges and reason why the kind of safety net that Medicaid and the ACA provide are so important. So on that note, two questions. One is if someone wants to respond to the issues around stigma, and secondly, the issues around raising an understanding, a healthcare understanding, now HIV science and treatment understanding. How do we do a better job in both of those arenas? Go ahead, Gabe.
Okay. So I'll just use California as a microcosm. In California, we have probably one of the most complicated healthcare apparatuses ever. I mean, not only do we have the Affordable Care Act, but we also have Medi-Cal, we have Medicaid, and then what a lot of folks are not aware of is that most of the regulations around Medi-Cal, Medicaid, or ACA are regulated at the health plan level. There's a lot of health plan regulations. And in California, we have health plans that look different from county to county to county. So when you talk about the transient nature of being homeless, the stigmatization of being homeless, when you talk about having a comorbidity like a substance abuse issue, there's stigma around substance abuse issues. Now you're stepping into this new, complicated, difficult, evolving, controversial healthcare landscape where there is a huge gap. When we think of education, I don't just think of the need for getting STD tested, but how do you go about getting STD tested? What's your copay fee look like? What laboratories, I heard earlier talking about laboratories. I mean, there's only certain laboratories you can go to. And so do you go to Quest Diagnostics? And so having this whole health literacy education is something that is really, really important with the emergence of the ACA and kind of the more complication that happened in California with some of the changes with Medi-Cal. Now PrEP is covered by Medi-Cal. There's just changes that just happen. And so getting our clients, particularly those who not even going to college, don't have a high school level reading level, and how do we do that kind of level of education and case management is very important and became more of an importance as ACA became more prevalent, at least in California for us.
One of the challenges around, I think, health literacy is that previously, most people who actually had HIV were getting their care from people who were HIV specialists. One of the challenges when you expand coverage is now there's a high percentage of people who are living with HIV who are receiving their coverage from people who are not HIV specialists, that their clinicians are not HIV specialists. And so it requires a higher level of literacy among patients and a higher need for treatment advocates in the mix. And again, these are resources that are available when there is a safety net, and those resources go away when the safety net also goes away. I see Ernest in the room, and I know that he will yell at me if I don't move us to an advocacy position, particularly given what's happening right now. So we have some late-breaking news that Senator McCain has issued a statement that he's going to vote no on the bill.
As well as Susan Collins of Maine.
Yes, exactly. And so literally, if this bill is to succeed, it's going to happen within the next 10 days or so. No, actually 8 days, right? 8 days. Next 8 days. Because on October 1st, the Senate will need 60 votes to pass the legislation. And so that requires those of us who believe that repealing the Affordable Care Act would have devastating effect on our communities, that we need to act now. And we need to be aggressive in that actions. And interesting enough, there are a number of senators who are Republicans whose state stands to lose a lot if this bill passes. They include Alaska, Arizona, Kentucky, believe it or not, Louisiana, where Senator Cassidy is from, Ohio, West Virginia, and North Dakota. Now, all of those states have at least one Republican senator. And so, and each of those states stand to lose between 35 to 60% of the support they get from the federal government if this bill passes. And so weighing in with those senators, but also weighing in with the senators from states that are solidly Democratic to make sure that they're out there talking about it, speaking about it, including those from California, New York, Massachusetts, and Maryland, which also stand to be big losers in this effort. We have a week to stop this from happening, and we need to make sure that we're reaching out and working as hard as we can. A number of organizations have sent out alerts this week. NASDAD, PWN, the Black AIDS Institute, I think NMAC sent one out, AIDS United sent one out, where there are instructions on how you can get involved and where you can call or fax or email. You can go to any of our websites if you don't know how to get engaged. But now is the time to do that. And if we fail now, the impact will be extremely devastating to our communities, and we need to be very, very clear about that. In your packets, there are two things. One are fact sheets about access in Black communities, and the other is a new report that the Black AIDS Institute released last week on the state of health care access in Black America called Access Denied, and there's a link to that report, and it has recommendations on what you can do. So actually, let's talk about that and what kinds of things can people do to impact or to help educate our legislators as they ponder this decision over the next week.
I don't know that education is nearly as important as making it known where you stand on this bill. And the information that we're getting at Age United is that the call volume, the email volume, and the letter volume is much lower than it was earlier this summer. So we can't rest on our laurels that we defeated, the Better Health Care Act last June. We have to now attack this one. And from what I understand from our friends in offices in the legislature, that those personal stories about what I'm about to risk or what my cousin, my sister, my brother is about to risk or lose in your state or in our state are the things that Congress wants to hear, and their staffs are actually taking those stories and they listen to them. They have no choice but to read those letters and to listen to those stories. But the volume for this act is lower than it was earlier this summer.
Go ahead.
Yes, so organizations like NASDAD and Southern AIDS Coalition are very active in the advocacy around issues in healthcare. And so many states have their own state-based advocacy groups. So for example, in Tennessee, there's the Tennessee AIDS Advocacy Network. Just saw them yesterday actually, meeting with them and just really mobilizing across the state and sending out alerts and keeping people aware of what's happening and how it would truly impact them, especially people living with HIV and AIDS, and engaging them in urging them and requiring them to be a part of the process.
Right.
I just want to add, just a couple of weeks ago now, NMAC hosted, I think many people know, we hosted a National HIV Advocacy Day, and we actually were able to take a couple hundred people on the Hill to meet with their representatives and staff persons, and we're still charging those individuals doing that follow-up. I think some of the communication that went out from all the partners, all the nationals, is just as Jesse was saying, it really is, we have to increase the call value, and those stories, that conversation. One of the other things definitely we noticed from the June fight is we don't have as much media coverage, you know. So even having those phone calls, why aren't media covering what's happening this time, where literally we could not turn the channel, radio, anywhere, and suddenly even media has gone silent. And that's black media and the mainstream media is very silent in this place. So I think also we need to be contacting the media sources. Where are they in this coverage? So definitely our constituents, but also media was a big part of helping make that happen, putting the pressure on. I know in DC on Monday, I think it is, there's another rally. So being present, whether it's in your city, your state, wherever, anywhere that people are showing up, you know, take your hour leave, take your half-day leave, and show up.
I want to piggyback on that a little bit. I know that 2 weeks after the election in November, while a lot of my colleagues were on planes going to DC, I was on a plane going to Sacramento. And I think that it's also, particularly for community-based organizations, aid service organizations, I think this is a moment where we really need to ensure that we hold our local and our state officials accountable, because particularly areas in the Deep South have historically, legislators in the Deep South have historically not made the proper investments in health and human services in their areas or for welfare services. And so I think this is a moment where we're like, okay, we need to hold our local elected officials accountable. And I know for us, one of the things that was a little disheartening for me when I met with state of California legislators is that they were actually really worried, like, you know, as one of the wealthiest states could be its own country. I mean, they even said, like, if the Affordable Care Act were to be repealed, we do not have the resources to fill in the gap. Particularly as California has one of the largest undocumented populations, right? Which is not even covered by the ACA. So like there's already state resources that are covering people who are undocumented, and just imagine what that burden would look like without ACA or with block grant Medicaid. So that's where holding your local state officials accountable is also necessary in this time.
I just want to add that I think one of the lessons from my mother is you can do two things at once. We're all keeping our eye on the effect of the hurricanes, right? Our hearts and our minds and our dollars we know are going there, but we also have to keep our eye on this bill for this next week. We really do have to do two things at once. You know, my mother could iron the clothes and watch the baby at the same time. We have to do both, or else we will find out in October that we are in a far worse place than we ever thought.
So before we transition to the next panel, because I want to make sure that we have time for a much larger conversation and we have the ability to engage the larger audience in both of these conversations. I'm going to surprise and draft Ernest again. Ernest, do you have, since you were one of our leaders on the Hill, do you have any guidance that you would give us on things that we really need to do over this next week, or particular targets that we should look to?
I think you did a good job of raising the states that are still in play. We have Shelley Moore Capito in West Virginia. I think over 50% of the population is Medicaid providing, using Medicaid. We need to really talk to them.
Ernest, actually, I did a bad thing. He needs to go to the microphone. the guy who's, I'm sorry about that.
Shelley Moore Capito from West Virginia is a senator who we should definitely target. Over 50% of the population in West Virginia uses Medicaid for their health care provision. Rob Portman in Ohio, both the governor has opposed this, and they have a significant Medicaid expansion that would be at risk. We should also be having conversations with Lisa Murkowski in Alaska. I think they have made some provisions in the bill that would benefit Alaska disproportionately, but I think with the pressure from the public about that may not actually play out. And they, once again, also have a significant Medicaid population that would be at risk. I think those are the senators that I would really focus on. I think also calling Susan Collins, because Maine also has a significant Medicaid problem. So I think focusing on those senators, we only need one, and Susan Collins has voted against these kind of repeal bills before. I think pushing on one of those other senators would be a really good idea. And so I think that's the best use of our time right now, is to focus on those senators: Portman, Capito, Murkowski, Collins.
And no, they specifically, Cassidy specifically put in the bill incentives for Collins to vote for. So they're courting her as one. So we need to make sure that we're focusing on that. We have a question from the audience that we want to send to Dr. Hildreth. Can you speak more about what it will take for our HBCUs to openly confront the spread of HIV on their campuses? So that's the question. No, a number of HBCUs actually have initiatives, but there are a number of HBCUs who are nervous about having an open conversation. And how can we help those campuses have a more robust conversation around HIV?
Well, I think one of the things that we have to do is to recognize what an important role stigma plays, even in this situation on campuses where oftentimes the problem is men having sex with men, and the stigma associated with that. And this problem is one that people are reluctant to confront or to even acknowledge that it exists. So in my opinion, that's one of our challenges, is having open conversations about these sorts of things is the main challenge. And I think some of the leadership is worried that if they openly acknowledge that these things are happening, there'll be an impact on their enrollments, on their support from donors. So it's all about starting a conversation where these things can be talked about and talked through. And to me, that's what it really comes down to.
Dr. McGoy?
So we're a family of HBCU grads, and I think one of the things that we talk about often is scaling up healthcare in general at HBCUs, where students can access healthcare and you're not walking away with the brown paper bag. But engaging, placing healthcare providers and engaging students in the process of their healthcare, and learning how to navigate healthcare at an HBCU. And then on college campuses, HBCUs, you'll find there's a lot of activism. And so in my experience at Spelman, we started a group called SHAPE. And so we were a health education group and talking about HIV and AIDS. And one of my mentors, Dazon Dixon, dating my 1997 when I was at Spelman, came on campus and started talking about HIV and AIDS, and was really one of the reasons why I got into the work. So, and then again, as Dr. Hildreth said, addressing stigma is certainly important on our campuses as well.
Great. So we're going to just have final comments from this panel, and then we will transition to the next panel, and then we'll open it up for a conversation on both of these topics. So we started with Gabe to open us up. So I think we'll start with Jesse on the other end and come this direction.
Thanks, Phil. Closing comment. I'm a person living with HIV for 35 years, and I want all of my black brothers and sisters to be able to live for 35 years and longer with HIV, and this bill is putting that at risk. President Trump and his appropriations message is putting that at risk, and the fact that we aren't talking enough about HIV. So my request to all of you is, in this environment, say, I know someone, I love someone who has HIV, and their life is at risk because of what's going on in Congress.
So for me, I think my charge is not to forget about the health disparities that exist in HIV and AIDS and who's impacted. We're talking about African Americans, and we're talking about men who have sex with men, as well as other populations. So that's important to address and keep in mind, and how the impacts our healthcare would have on those populations. Get involved, do the education, reduce stigma, and be a part of advocacy.
I guess from my perspective, HIV represents one of the many disparities in health in our country that is totally unacceptable. It sort of represents undervaluing certain persons in our society more than others, which is totally unjust and uncalled for. So for me, it's a larger issue about equity, health equity for sure, but health is not the absence of disease, it's many other things as well. And we need to be having that larger conversation. And I think that is something that we're trying to do at my institution, trying to push for that. But I would just leave that thought with us.
First of all, thank you, Phil. I probably my thought, I think like Jesse, is a woman been diagnosed for over 27 years. A couple of things, if I was to speak my truth, that I really would love for us to do is to call it what it is. You know, we are still in 2017 looking at homophobia. We're still looking at race and not addressing those issues. There's still so many words we won't call it to be true while we're having this challenge, when we're talking about poverty. So I will hope that we will leave here and begin to speak truth and call those words what they are, regardless of what our boards and our community and our parents want to say. Be truthful. Sit at your churches and your offices and call it what it is. It is ugly. But when you speak what it is, you get to have the conversation how to change ugly into something new and something beautiful. HIV is not ugly. I am not ugly. What we stand for and what we do is not ugly. And we only know that because many of us have been bold enough to charge people to have the conversation, to change, and to change it from what we thought was ugly and cruel to be beautiful and life-sustaining.
That's good. Thank you for that, sister.
And I'm not going to take an offering.
Right. Pull out my tithe. I am personally making it a mission of mine to invest in the future of the next generation. I'm already seeing even those that I call baby brother, right, that are behind me in a generational group, are already taking positions of leadership. Gonna outstrip me, you know, and I'm only 30, and I already could feel them, you know, racing up behind. So, you know, none of this work can continue or grow or evolve without the investment of the next leadership. And so I think all of us in our individual roles and our individual agencies, even our own families, take a moment to invest in someone of the young, because they will be the ones who will ascend and take on this mantle. And we want to be confident that that generation is supported, secured, and celebrated. So. Ashe, though.
Thank you very, very much. There was one question that I meant to ask, and I missed it. So I'll lay it out there for us for the open conversation later. And that is, when we look at some of the states that I named that stand to lose the most, and I think Dr. McGoy raised the issue around the opioid epidemic that is going on. And repealing the Affordable Care Act is going to have devastating impact in states where that is a problem, in the Indianas of the world, et cetera, et cetera, et cetera. And I think that earlier there was a conversation, again, eavesdropping on Marcia and Gloria. I get so much information by eavesdropping, is the issues around the intersectionality of it. And one of the things that we need to pay attention to is that, as Dr. Hilbroth said, that HIV is one of the areas where we are disproportionately impacted. But as they say, when white folks get a cold, we get what? We get pneumonia. And so no matter how you look at it, no matter what disease state we're talking about, we tend to be impacted at a disproportionate level. And that also, I think, includes the opioid epidemic as well. And this is a topic that apparently a number of folks are interested in, even if they're not as interested in HIV, and I don't necessarily know if they understand the impact of repealing the Affordable Care Act on that issue. So if we can give our panel another hand. And we're going to invite our second panel to come to the podium, and while we do that, yeah. Okay, great. Make sure that you're writing down questions that you might have, and we'll make sure that we leave time. We're deliberately trying to leave time so that people can so that all of us can have a conversation. We're going to ask our panelists that are leaving the DS if you can sit in the front row. If we're going to have all of our first panelists stay on the front row, that would be great, because we're going to come back to you later on. So, as we did with the opening panel, we're going to have this panel also share with us a fun fact. And at the end of our fun fact round, we're going to ask A. Cornelius Baker if he will provide us with a very, very brief overview of PEPFAR and where we are in PEPFAR with regards to the current climate, both domestic and in other parts of the world. So, Ms. Gloria Crowell.
Good afternoon, everyone. You guys are looking like you have that afternoon drag right about now, but come on, let's still keep it moving. Fun fact about me, I am a mom of 2 boys, and they are both Eagle Scouts.
Wow. And a husband who does serious barbecue, but that's another matter. Okay. Well, the newest, funnest fact is I'm going to be talking to Gabriel about teaching me how to snowboard.
A fun fact is that I began my education in a 2-room schoolhouse where there were 26 students, and I spent 3 years in the 1st grade.
All right, go on, honey. Must have been fun.
There is no fun fact after that. Besides, I failed geometry 3 times. But my fun fact is my mother went into labor climbing an apple tree. And and was in labor for 36 hours. Okay. So thanks everyone for being here, and that first panel, obviously, with the news of the day is so timely and relevant. And I think this panel, of course, looking at not only the news of the day, but how we also continue to mobilize and use all of our researchers, particularly those grounded in faith, to bring an end to the HIV epidemic in its totality. First, we always want to give acknowledgement to Congresswoman Barbara Lee for her leadership in both the domestic and the global response. Many of you know about the global response and PEPFAR and the epidemic in general, but I think there are just a couple of things I'd like to highlight as maybe some stage setting for today's session and for this panel. As you all know, the epidemic is still at 37 million people worldwide, and that 17 million people have access to treatment services. So about half of the epidemic still has no access to treatment. And we also see within that huge disparities, not only about access to treatment, but who also has access to treatment. That we see particularly in the African continent, the continuing amount of deaths for children. while in our country we've made considerable progress, and we now have about 100 to less than 200 children being born a year with HIV, particularly in Africa, that number is still in the thousands, and that we still have 330 children born each week with HIV and about 380 children who die each week up to adolescence with HIV. Only 43% of children have access to treatment primarily in sub-Saharan Africa. And we see the global disparity among access, and well, not really access, but seeking services in HIV testing among men. And that we still have a continuing challenge getting men to get tested and into services. And that's, similarly here in the United States, as well as in Europe and in Africa. So really thinking about how we exercise more leadership to get men into care. And in Africa, especially important to break the cycle of infections among young girls. And so those are sort of big challenges as we look at it. The faith response, as you know, has been essential since the beginning of the epidemic. Here in the United States, the first responders, as we're thinking about hurricanes and earthquakes right now, the first responders in the United States who gave beds and treatment and help the dying were Cedars-Sinai in Los Angeles and St. Vincent's in New York. So those experiences were grounded in faith. And today in Africa, most of the clinics and the hospitals and the care provided, and still a majority, is from Methodist and Anglican and Presbyterian and Mormon missions that are providing care across the continent. And so strengthening that faith-based response, which often, they provide a lot of care and we don't provide a lot of the funding to them. So the funding out of those services comes out of their faith traditions, and so they are absolutely essential partners for us to have. And just as we were talking earlier in the first panel about that continuing presence and mobilization in the United States, when President Bush created the PEPFAR, it was grounded in his own faith, but it was also grounded in the faith traditions of Baylor University, so our academic traditions of faith, but also out of evangelical ministries that believe that we should be providing care and treatment that we had to all people. And before that, the Life Initiative created by Sandy Thurman and Bill Clinton was founded out of those traditions, and along with the leadership of many people in the United States, David Dinkins and Calvin Butts particularly come to mind. So today, our big challenge, of course, is that our leadership, and we know that Congresswoman Lee's own leadership comes out of her membership at Allen Temple, which continues to be a leader in HIV care in Oakland and advocacy in Oakland, but also as a vocal supporter of the global response. And so I think the big challenge, and what I would want to leave our final comment on, is this week in New York at the United Nations, in his lunch with the African leaders, President Trump pledged the United States continuing support to Africa and other nations through PEPFAR. And Secretary Tillerson released the new PEPFAR strategy for 2017 through 2020. And the fourth point of that five-point strategy is to engage both faith communities and the private sector in our efforts to bring an end to the HIV epidemic. So this panel, I think, is very relevant and timely to Secretary Tillerson and President Bush Trump's commitment this week, and how do we mobilize that faith response so that we can get to an end of HIV and new infections in 2020.
Thank you, Cornelius. And since you called out Allen Temple, we're going to jump around and go directly to Allen Temple. Gloria Carwell, who's been at Allen Temple for a while and has been actively involved in the work that they do both domestically and globally, being a key player in the work, particularly that Allen Temple was engaged in with Dr. Scott in Zimbabwe. And many of us remember that call from the jail cell in Harare. So, Gloria, can you talk to us about Allen Temple's experience as a faith-based organization on the global stage?
Well, medical providers in the room will really resonate with this because of that Hippocratic oath brings together both the medical and the spiritual. And so you can't really be the most proactive and effective physician really without your patient kind of having a spirituality component. And I think that's all wrapped into that little symbol that creates in the medical industry. So what happened at Allen Temple in Oakland, California, we actually had an AIDS ministry that goes back to 1987, where we had a mom whose son passed away of HIV, and our pastor was very supportive of having an AIDS ministry to uplift and really share with the broader community what her challenge was and what the community's challenge is. That started back in '87, and by the time 1994 rolled around, I co-chaired that AIDS ministry along with Dr. Robert Scott, who had an untimely death and passed away in 2009. We co-chaired that throughout all of those years, and I still chair the AIDS ministry at Allen Temple Baptist Church. In addition to, at that church, we actually have a nonprofit that is the Health and Social Services, and I'm the executive director of that, and we do all of the health-related, social service-related programs at Allen Temple. HIV internationally, Cornelius is absolutely correct. I mean, I don't know one program in Africa that is not somehow, some way connected, an AIDS program that is connected to a faith tradition, Methodist, Catholic, I mean, you run the gamut, UCC, all over the place. Because of the resources, let's face it, nobody really wants to talk about HIV. It's not sexy, people are dying, and it's very expensive, and it's resource driven to really get people what they need and to continually get people what they need. So one of the things that Allen Temple did very effectively throughout, I would say, all of the 2000s is really kind of sneak medications over to Zimbabwe and help treat people who were living with HIV. We did this, why? Because the government did not have a good relationship with the global AIDS. The government of Zimbabwe did not have a good relationship with PEPFAR. There was no relationship. Therefore, there was no access to medications. And so how were people going to live unless there was some alternative movement? And that's what Allen Temple AIDS Ministry was able to provide. Somehow the government of Zimbabwe found Jesus and was able to have an expanded global AIDS presence, and actually medication became widely available throughout all of the people in the country who needed medication somewhere around 2010, 2009, 2010, somewhere around there. So really our job, we kind of worked ourselves out of a job. And that's really what the goal should be in doing this international work. You want to work your way out of a job. And so the government is able to support people who are living with HIV throughout the country. However, Allen Temple AIDS Ministry still ships medications to Zimbabwe for people who are on kind of second line, third line regimens. So, even though we're not taking large delegations of people to Zimbabwe every year, we're still shipping large packages of medications to Zimbabwe, and we do that every quarter still. One last thing I'll say, and I'll turn this over. You heard from the previous panel about this also international work around faith communities coming into where hurricanes have been and earthquakes. And we have that challenge going on right now. And so I don't think that the people of Puerto Rico and Dominica, Turks and Caicos, Bahamas, all of those places that have been devastated all have people who are living with HIV. And we should be cognizant about that as we are moving on. We also should, make FEMA step up their game and see how they're gonna contribute to the wellness and support of people who are living with HIV in those devastated places.
So Marcia, as we go back down the row, you're doing a lot of work these days across the diaspora. And of course, PEPFAR focuses across the diaspora in developing countries, but also the engagement of black folks wherever they are. I know that in our work, one of the things that we've observed across the diaspora is that black folks are disproportionately impacted wherever we are, and in some cases, particularly in Eurocentric places, to the same proportion. So that if you look at the demographics of the AIDS epidemic in England or Germany or France or Canada or the US, that they all have kind of, it's as if someone took a snapshot and just changed the geolocator of the photo. So with that, how can we respond to the broader diaspora when we talk about HIV, and how can we expand the role of faith-based organizations in that effort? Yeah.
Well, thank you, Phil. And a couple of things I'll just say to sort of frame the challenge that Phil has presented to us. And one is, a few years back, several of us were at a U.S. conference, and we were looking around the room and sort of were trying to have a conversation about how are we doing as black people around the HIV response, even just domestically first. Like, just let's take a look and see. And then let's just think about how are we doing globally. And while we spent a lot of time talking about people and populations and people who are living with HIV, we sort of said, let's take a step back and take a look at the people who are working in HIV, who are black people who are working in HIV. And if you look at what has happened over the 35 plus years of the epidemic, there are a lot of black people working in HIV domestically and globally. And we have a lot of experience and knowledge, and the challenge is about creating opportunity for us to begin to explore different ways of framing the discussion. And so along the way, in addition to the work of the Black AIDS Institute domestically, the Black AIDS Institute and the African Black Diaspora Global Network in Canada pulled together a meeting in Toronto to really raise the questions about the diaspora. What are we doing? How are we looking at this? How are we understanding this? And in addition to that, the Black AIDS Institute also would take a group of journalists to the Global AIDS Conference to have folks really take a look, and these are African American journalists, to look at the epidemic globally, but also to place the US epidemic in the context of the epidemic globally. And I'll never forget the report that came out and said, if Black America were a country, we'd be the 15th most heavily impacted in the PEPFAR lineup, right? I think it was 15, 16. And that was the beginning of this sort of bridge conversation between black communities in the United States and black communities globally. And the folks in Canada had started this diaspora network because if you look at the data in Canada, you have all these black people from all over the world that are living in Canada and disproportionately impacted by HIV, some acquiring HIV when they get there and some acquiring HIV, bringing it with. So in fact, this year I just would offer up to you a little side piece that there's a new website, HIV and Migration, that the African Black Diaspora Global Network out of Canada has created to look at what's going on across the diaspora as it relates to HIV. And how are we experiencing the response? And how should we be managing the response? And clearly, this is really why we love the caucus, right? It's a family discussion. And the reality is, as Phil said, we are the most impacted across the globe. It's black people. And so the question becomes one of where do black people gather and how do we educate and impact black folks around this epidemic? So faith tradition, and I'm glad I'm here with Reverend Saunders because, Reverend Saunders goes way back with many of us. We remember when he stepped out front as a faith leader and put his arms out and said whosoever, welcoming all to the table. And within the faith tradition, in the black community, we go to that institution for safe space, for education, for solace, and for understanding what we should do next. Well, that's the case across the diaspora. We are people attached to faith traditions and faith communities. And it is critically important in our family discussion that we begin to think about, across the diaspora, how are we messaging in our faith institutions? How are we bringing them forward in our conversation, helping them go through a process of, I'm going to say first, evaluation. How are we doing? We got people in our congregations that are impacted by HIV, but how are we doing? Secondly, what are the assets? Allen Temple didn't have to create clinics. They didn't have to get drugs over to people in Zimbabwe. They didn't have to have an AIDS ministry that's nearly 30 years old. We have to then ask our faith traditions, how are you going to play a part in this? And what part can you play? And you know what? We're going to step out and step up front and say we're going to be a part of that. And then finally, I would offer up that the message from the faith community, and I'm going to say, regardless of tradition, we, as persons who participate, need to really engage on how our leadership in our traditions are messaging the work and messaging the issue. And that's up to us. I just will bias it all by saying, I was just at the resistance session. How many in here were at the resistance session? Okay? The resistance session said it's up to us. You can't look to us or look to you and say, okay, it's your job.
What are y'all doing?
What are y'all doing?
How are y'all gonna do it?
Right. It is all of us that have to appreciate that we are attached to faith institutions. And in that attachment, we should begin to use that relationship to shape it so it responds and respects our needs.
Yeah.
And that's what PEPFAR's been doing. That's what the leadership has been doing over the years to try to say, come on, we're invested in this. We can regroup on this. It's what Baldwin Gilead has been doing. At one point, they were in 5 countries, not unlike Allen Temple, 5 countries working on the global response because recognizing the Catholics, the Protestants, the Muslims, people go to church. And more than anything, their behavior reflects some aspect of their belief. We got to get those people who help us understand what we believe and how we believe. And faith into action. And that's this guy right here.
How many folks in here are involved with any kind of church, a faith community?
How many?
Anybody? You go to some kind of a faith something.
She knows what to do.
So the challenge is really up to you to, because I don't think our job, because we're old timers in the struggle, so our role is really not just to,
What you talking about, Willis?
What you talking about?
older in the struggle. Our role is really not just to provide answers, but really to inspire you to go back and make a difference in your community.
So since Marsha called him out, we're going to turn it over. I think we're trying to do a logistical thing for you, Reverend Sanders. So, Reverend Sanders, as the only, I think, minister on this panel, will kick it over to you.
First, I need to add just a little bit to my little-known fact. My mother was one of the 2 teachers in the school, and I was in the 1st grade when I was 4 years old, 5 years old, and 6 years old, because she had to keep her enrollment up in order for the school to continue to exist. All right. But it did help lay a good foundation for me. It's really interesting because a lot of what I need to say and want to say is captured very quickly, but there are a couple of slides that are going to be up there, and this will fit where we are. Because you've said it in terms of, I think, laying the foundation. That slide is really important for what I'm here to say to you that's up there right now. And that is that when you talk about the global issues as relates to HIV and AIDS, you really do have to figure out how you frame it. And the frame is spirituality. In many instances, it does translate into religious institutions, and it translates into religion. But I always tell people, you know, we're all spiritual whether we're religious or not. You're spiritual by nature, you're religious by choice. But one of the things that Sarah Lincoln used to always say about this whole business of spirituality is that if you talk about it in relationship to Africa, Africans frame everything in terms of spirituality. As a matter of fact, it's interesting how much that has carried over to our American experience, because it's interesting to note that black people all the time will have the response to just about anything that happens, and they'll give it some kind of spiritual flavor. You know, it happened because it was God's will in one way or another. So the word that came up over and over again in this conversation so far is that word right there, intersectionality. But the way you get there is understanding where we have to take our faith, which ends up being a fundamental part of what many of us have had as their life experience, not being really that particularly exceptional in terms of one dimension of faith. I always tell folks it can be whether or not you were Buddhist, you were Sikh, you were Muslim, you were Catholic fits in there. But anyway, if you were a follower of Jesus, whether you go down the list. There's a way in which this thing works for us. This thing of intersectionality first has to be understood that what makes it work, it's a universal dynamic. That slide that's up there is just a slide of a community. And it makes you realize how culturally, when you come to any intersection in life, there are all kinds of things that are constantly happening that allow you to be able to, if you're going to understand where you are, to be able to dissect and to be able to translate what's going on in a way, even if it turns out to be from a city in an urban area like that first slide showed, or whether you're going down a road in South Africa like that, where there's a giraffe crossing the road. The intersectionality dynamics are there for everything. So there's a way in which it might even end up being like that one, with with that scene with Tom Hanks in Castaway, where you get to these points in life where you have to make decisions. So, but let me just put it to you like this. Keep going, just one more slide there. It's kind of like this. You can see how intersectionality works in terms of just moving through our everyday realities. If you took that scene right there and talked about it in relationship to HIV and AIDS, for our communities, you could easily talk about it in terms of how our communities have been cut up, how they've been dissected, how they have been exploited, in terms of being the places where indeed the what they considered to be the avenue of least resistance. I don't know if you understand this, but just about every interstate system in this country, when you look at urban areas and the ways in which that impacted the isolation, the ways in which that impacted, because you talk about what the CDC has told us about HIV and AIDS, that helped to debunk the sense of somehow being less moral, less ethical, and somehow, other than are super sexed in terms of who we are. The issue that they came to is just simply to tell us it has a lot more to do with social stratification. And a lot of that social stratification in modern terms is the byproduct of experiences like the way interstates got built and the like. So what I'm saying is don't get yourself locked into thinking about this whole business of HIV and AIDS and how it's impacting our communities as being one-dimensional. The biomedical responses are important, the ways in which the analysis has been done in terms of the psychosocial dynamic, all of that's important, but you need to understand it affects every dimension of who we are. And what we have to do is we get to the point where we understand that this conversation, and this is what I think you were just saying in terms of your last experience, this conversation has to move to the next level. And a part of moving to the next level is coming to the place where we get to the point where we deal with how to think versus what to think. So much of what we deal with in our communities is based upon what to think that we have been taught by persons in disciplines whose construct of thinking has been so narrow that it has limited the ways in which we're able to create new responses. And we're the people in the faith community and everywhere else that have to be about the business of saying that you do not have to deal with the biblical limitations, you do not have to deal, with any of the other limitations, whether it be the Quran or whether it be the Bible or whether it be the Gita or whether it be any of the other things. There's a way in which all of those persons we associate with those faith traditions were the people who pushed us beyond the ordinary in terms of how we think and how we look at what's going on around us. So the business of how to think versus what to think. And we have to get to where we get beyond our fear of empowering and licensing people to think in ways that go beyond the ordinary. I should tell you that one of the more interesting experiences I've had, and this is just getting to the point where you can think out the box. One of the most important experiences I've had in recent years in dealing with HIV/AIDS was at a NASAM conference a few years ago. It's only been about 3 years ago. We were in Atlanta, and I remember, what do they call those young men that they come and train every year? Crips. Crips. They had the Crips come, and I did a little talk with them. And afterwards, 4 of them who didn't know me came up afterwards, and they said to me, Reverend Sanders, are you gay or not? Now, I told my wife and my congregation when I got home that had to be the highest compliment I think I've been paid in recent years. Because what that said to me is that you must have gotten to the point where the way in which we were addressing the issue allowed people to see that you did not bring the baggage that ends up being diminishing or minimalizing or hurtful or all of that in terms of how people look. So I'm just saying you have to be bold enough to put yourself in a position to deal with being challenged in that way. Why? Because in too many instances, what ends up being the greatest fear is being stigmatized in a fashion that might make people look at you in a way that becomes discrediting in terms of what you have to say. It's kind of like with racism. Racism won't end until the people in the room, where there are no black people in the room, but the issue is dealt with forthrightly and aggressively by the white folk that are there. Okay? So it's the same thing in terms of us and how we deal with this. So the one thing I'll say to you about this little series of slides I gave you is the first slide. If you notice, every slide I've showed you has that image at the top of the whosoever. So the image I've come to is to use this. If you look at that, it won't take you but a minute. Leave that last one up there. If you get to the point, there's a way in which you realize that it doesn't take you but a minute to look at that slide and be able to realize it has all these symbolism, all the symbolism and all the images that are associated with those of us who are followers of Jesus, right? It's got the chalice, it's got the bread, it's got the wine, it's got the wheat, it's got the cross, it's got the kaleidoscope of colors, which is all another thing. If you look at the image in the middle, there's no face, but it does have what clearly is a halo above it. And if nothing else didn't make you realize what it is, you see the holes in the hands, right? All of that, I think, is real significant if you're thinking in terms of followers of Jesus and what very often is referred to as institutional Christianity. What I tell people in recent years is that the most important thing about that, which I think then can represent Jesus, it can represent Buddha, it can represent, the many of the prophets of the Hebrew Bible, it can represent those who are part of the Eastern and all the other traditions, is that what all of them call us to do, and this is what's most important to me in that, is stretch. Mm-hmm. Until you can stretch the ways in which you think, stretch in terms of what you believe, stretch in the ways in which you look at people and understand. So what we're about right now, if you're going to answer the question that you said came out of your earlier session, is how do we facilitate, how do we promote, how do we end up being the nurturers of that stretching? And one of the things we have to do to effectively achieve that is to get people to understand how to use the dynamics that we have already got at our disposal in a fashion that allows us to get results that are different from that which we've had in the past. Another word other than intersectionality that's been mentioned many times in here today is this business of conversation. Howard Thurman had a great line where he said once about how we use words. He said, we take words that are powerful, significant, and words of great meaning, and because we use them too loosely, because we use them without clear, sense of focus in terms of depth of meaning, that what very often ends up happening is that very strong, important, and powerful words start to, and these are his words, start to leak. And what he meant by they start to leak is that they're not tight, Y'all, conversation is one of those words. We keep saying we got to have the conversation, we got to have the conversation. But it's in conversation that very often creative energies flow. It's in conversation that we find ourselves with transformative moments coming in terms of awakening and in terms of the realization of new possibilities. So don't let conversation become something that you do in terms of just a focus group, okay? Or in terms of the way in which you might have framed it in terms of you've been taught to do your research, but let it be something that lends itself to creating an environment, an atmosphere, and a situation where people really do stretch, move outside of the box, and begin to think of things in different ways. We're learning, y'all. And this is what you need to do to make it work. It says, you know, Paulo Freire is important. He says transformation is only valid if it is carried out with the people and not for them. Now, two things on that one, and I'll stop. One is, with the people gets to be real important, because too many of those who need to be in the conversation are left out of the conversation for a lot of reasons that are very common. One of the things that we've learned to do in the work that we do is, y'all know the 90-90-90 model? Okay? And I'm sure that it's going to be effective for some folk, but we're spending our time focusing on the 10-10-10. Because we know that there are people who are the discounted, the disinherited, and the lost, you know, kind of the kick to the curb populations. One of the reasons why we've been able to collaborate effectively with Meharry is Meharry is one of those places that does the work well in terms of how they're going to get to the 90-90-90. We're the folks that do the work that's going to try to get us to the 10-10-10. Yeah. We serve the people who are in active addiction. You know, they show up as high as a kite every day. You know, they've already cussed everybody else out. They've already proven to be non-compliant in every way you can imagine. We try to make sure that we have a sanctuary and that we have a safe space. I mean, that's a part of just saying you got to learn how to stretch. Or it's like what happened with the hurricanes recently. Y'all, an interesting comment on the hurricanes that got me, and it's the way it is across the board for us. It said that in the last, since the year 2000, there have been 7 major floods in Houston. Only 3 of them had names. Now you think about that for a minute. It's very powerful, because just like only 3 of them had names, think of how many nameless people there are that we need to be addressing effectively if we're going to address HIV and AIDS. And in many instances, the stigmatization is because of the fear, is because of the ways in which people in our communities are trying to deflect attention from any sense of identification with those who we have decided are folks that we want to be associated with. That's where stigma comes from. The stigma, y'all, comes from our stuff, our insecurities, our uncertainties, our fears, our doubts, our reluctance to deal with the issues that we don't want to deal with. It's just like talking about LGBTQ. I tell people all the time, get Q right, y'all, and you'll help us with this disease. Because Q can be queer, but Q can also be questioning. If you say Q in terms of the familial term used between people who might be gay, or might be lesbian, or might be bisexual, you're talking about probably less than 10% of the population. If you say Q as questioning, you're talking about more than 50% of the congregation, of the population. And what it is we don't want to talk about sexuality. So until we can stretch to the point where we're open, honest, and forthright, you got to stretch. That's all there is to it.
And I just checked with Phil if I could just give you an illustration, and it grows from PEPFAR. And I was at the UN General Assembly yesterday, special session on HIV. And that session was chaired by the president of Uganda. And I will tell you, how many people know what's been happening, sort of reported in the press in Uganda over the last 10, 12 years? How many people, right? That there's been some concerns about violence and safety and support for the LGBT community and people living with HIV, and the state, the assembly of the country was passing legislation to outlaw homosexuality, etc. Well, fast forward. Yesterday, the president of the country gave the most empowering, impassioned address on HIV, how far the country has come, where it needs to go. And I would just say to all of you, find it on Facebook, find it online, and look at the speech. Museveni gave an extraordinary, and that's because of the work of PEPFAR and because of the work of the USG and the USG's commitment to engaging and never stopping, right? So some people would have said, don't do it. Why bother? You know, it's no chance. You know, there's just a kind of like roadblock. We can't do anything, right? And here is this black African leader who was at the back of the class for many people, who was at the front of the class and had 8 other heads of state committing to reaching the 90-90-90, committing to mobilizing their own national resources to address HIV, to match with what the USG has done, to match what the Global Fund does. Folks were amazed But you have to watch this speech. He talked about HIV like all of us in this room can talk about HIV. And you would never have thought, people would, oh no, he was well-versed, well aware. It was a leadership country in the response as the early PEPFAR days began. And now it's back at the front of the line. And I'm just adding to this conversation about we're not stopping in the conversation. And we're continuing to educate and invite people to join in engaging around HIV in ways that in the past perhaps they didn't know, in the past perhaps they didn't understand, in the past perhaps the politics didn't work right, in the past who knows what it all was. But you know what? Those 9 people are here today, and we want to support them and make sure that another 20 join them. And that's diplomacy at its most unbelievable level. Not giving up, keeping educating, keeping engaging, having people represent and speak and talk, and just bringing people along. You all have to see it. Don't read it, look at it, to the point. And those of you who know, he told a joke about the history. He told a little joke. He's saying, you know, he gave the whole history of the epidemic. And he said, when the first people came to him and said, you gotta worry about this disease. And he said, well, why? You know, we don't have any Haitians here. We don't have any hemophiliacs here. And you know, everybody knows we don't have any homosexuals here. And everybody knows what that was and what he was saying, because he recognized the irony in where they are today from where they were.
I'd just like to share one thing too. I'm gonna just break in. This is the challenge I think that I would like to have for all of you out there today. And it is, you have to kind of change the rules as we go along the way. You have to stretch, you have to change the rules, and you can't give up. So one of the biggest challenges is to make sure that everyone knows their status. Everyone gets an HIV test. That's really the basic bottom line. It's like, did you get your shots? Did you get your flu shot? Yeah. Did you get your HIV test? It should be kind of the baseline thing. That's where you can start here and then move up from there. I would just like to challenge you to go back to your communities and encourage others to know their status, to know what their HIV status is. I think it's one of the most important things. CDC says that everybody between the ages of 12 and 65 should be tested for HIV. Raise your hand if you've been tested for HIV. Praise the Lord. Now go back to your communities and get everybody on your block to do the same.
Amen.
So we have 2 questions that have come forth from the audience. So the first question, I'm not completely sure who is authorized to answer this question in the room, but the question is, does the Congressional Black Caucus support single payer? And if not, why not? I'm not sure if we have a member in the room.
I don't. Yeah, your boss.
Yeah, so.
She introduced it.
Yeah.
You know, whatever you want to call it, universal health care, Medicare for all, single payer, it means everyone should have equitable access to care, so.
Yeah.
Okay. So, second question, with so much focus on Black MSM, what is being done to engage other populations vulnerable to HIV, such as heterosexual Black women and individuals over the age of 50 in prevention and treatment efforts domestically?
Did I write that question?
Yeah, right, you wrote it.
So,
Can I just say, picking back up on what Gloria just said, I think what we have to do in order to really answer that question honestly is that we have to have serious conversations with our public health departments about the approach of whether we're going to target the limited resources we have or whether we are going to go for general engagement. We know that of the women who are living with HIV, 60 to 80% are Black women. That's just a fact.
We know it.
We know it. okay? But depends upon the community, it may be 10 to 30% of the overall population of people living with HIV. So the challenge is, with targeted resources and limited resources, where are you going to engage your epidemic response in order to impact the most affected communities? And that is the conundrum, and that is the challenge. The challenge is really not, I'm going to say it this way, but that we don't know who's living with HIV and who's impacted by HIV. The challenge is we have scarce resources and this requirement that you can't just go test everybody. You have to test folks that are in these high targeted areas, heavy burdened areas, which makes sense. So key populations as defined globally are men who have sex with men, transgender women, commercial sex workers, and people who use drugs.
But I'm the rule breaker. So Marsha just said you can't just go test everybody, right? My theory is that you should, and you can go just test everybody, because that is how we're going to get to baseline information. We're going to know who needs to be on treatment and who does not. So the faith community has always found a way to do things outside of the box, break the rules, do things differently. And I believe it's true. You should go and talk to your local health department about doing things differently. However, faith communities can do things differently. We're not bound by what the State Department and CDC says. We could actually go raise our own money, buy our own test kits, do our own HIV testing, and not really be bound in the box that says you really should be testing this population of men who have sex with men between the ages of 18 and 24.
Well, I think that the other thing for us to think about is that these are not necessarily either or constructs. You know, that we have different epidemics, both domestically and certainly globally, you know, and we have all of these new tools. No, we have surveillance tools that allow us to identify the hot spots of the epidemic down to zip codes and census tracts. So there are zip codes, there are census tracts when absolutely, when you look at the community viral load, it makes sense to test everyone. There are other zip codes and census tracts where it is a more appropriate use of resources to target. And so these are not mutually exclusive constructs. It is really about paying attention to the epidemic. Now, and that it's not one epidemic. It's not even just one epidemic in a black context. There are multiple epidemics, and responding to the epidemics that are before us and engaging folks in that way. So I think that Marsha's point around understanding the importance of targeting, the importance of triage. There are medical providers in the room, and so they understand the notion of triage. But also, it's equally important, particularly in black communities, to figure out ways to have general messages. Because one of the challenges we're dealing with today in black communities is that even in our communities, with the numbers we see, vast numbers of folks in our community think the epidemic is over because we've given up on general messages. And one of the critical ways that you can reach target populations is by also having an overlay of general messages that are happening.
2 points. One is that we know that if you get someone onto treatment and you suppress the virus, it's as good as a vaccine in preventing transmission to other persons. But in my opinion, until and unless there's universal access to treatment and care, there should not be universal testing. It's as simple as that.
So we have exhausted the cards that have come forward. There's a mic in the center, and there's roaming mics, and we also want to now open up the floor for our first panel and our second panel, including the conversation or the debate that we just entered into. That's a legitimate area of discussion. So it's kind of, as they say, let's have a family conversation. How do we address the AIDS epidemic as I think, how do we address the AIDS epidemic domestically and globally during the Trump era? We have a hand over there. Oh, okay. So you don't want to be on the camera? Okay, great.
I'm very emotional because myself, I'm living with HIV. What upset me most is because many times people are not interested in hearing my pain and my suffering, even what I can offer as a human being, is basically taking my pictures. And I'm not talking about these people, these cameramen. It's basically in New York City. I'd be sitting on the subway, everywhere, people just taking my pictures. They used to invite, probably some of them invite me to events just to take my pictures. As I told them, I don't have a problem. Actually, I will allow you to take my pictures if you allow me to tell you the story, the hell that I've been through. If you don't want to hear my hell, do not talk about, take my pictures. That's my basic story for anybody. Otherwise, no, a lot of my pictures are out there. I've been living with HIV. While I'm HIV, I had to care for several disabled members of my family who are suffering from mental illness. And I raised a daughter who's, I raised two daughters. One is my niece, whose mother is mentally ill. I never get a chance in the community to even get a little bit of respect at all in the Haitian community. What they did in 2010, you had a group of several Haitian radios start calling me whore, start calling me even my daughters, all kind of names, based on what? And a situation that basically were lies. I had two incidents in New York City. One was a situation with a councilman, and if people hear the situation, the circumstance that create the situation, they would not even blame me. But they did not blame me. They start blaming they did not blame him. They start blaming me and then harassing and attacking my family, blocking my family from getting social services. So the burden of my entire family basically fell on me. My niece that I'm talking about, my adoptive daughter, her mother's living in state institutions. I met this council man, not the man. I didn't go to him first. I went to two state elected officials. They directed me to him because they said he was the person. These people were not in my district. He was my councilman. Something happened, sexually happened, but they never blame him. They blame me. And that's something that happened close to 30 years ago. 2010 until now, they make my life a living hell. And they want me to, I went to the United Nations trying to get them to get involved in the situation. Everybody been ignoring me and my family, my hell. And I have not even told you the story. That's just a cover, and there are other people there. We need to start addressing the issue truthfully, honestly, and frankly. And I'm really tired of it. If I lost my job, so be it. I'm tired, God. I want help.
Thank you very much, and thank you for sharing your story and your pain with all of us here, and for creating this sacred space for us to hear this. I only want to share with you that what you have brought up is something that some of us have been talking about for a while, and just this past week, we were in 2 days of meetings talking about HIV in the Black community and how there is a need to create this kind of sacred, safe space so that people can talk about the hurt and the trauma and the wounds. And in the Black community, we have fallen short of creating that space. And so I would just ask for all of us to honor this woman and what her pain is that she's expressed, and to think about how we can go back to our own communities and in our own settings and in our own faith institutions and really talk about the wounds and the trauma that exist in this world of HIV. It may be outside HIV, but it's definitely inside HIV. And what we heard at the summit this week was you know, wounded people sometimes wound each other. And wounded people sometimes can't take care of other people. the way that we know people need to be nurtured and healed and held. So I would just ask for all of us to appreciate what has just been shared and just to know that there are indeed millions who have had to bury the pain, the discomfort, the trauma, and we haven't created the spaces to open that up. So thank you.
Thank you, Marcia.
I'd like to just go a little further as well. I mean, because, you know, in thinking about the moment that we're in, I mean, Reverend has brought up the 90-90-90 goals, which are, of course, about ending the epidemic and getting 90% treated, 90% tested, 90% treated, 90% virally suppressed, as well as our overall prevention goals. And, you know, in the comments that we heard are also reflective of the epidemic today, especially when we look at where the vast majority of epidemics are, of new infections are occurring in Southern Africa, and mostly among young girls. I mean, someone asked, where do we engage in the discussion about black women? And if we really want to have a serious discussion about it, those cases in the United States are important, but if we're really serious about the lives of black women, we need to be serious about the lives of black African women and young girls who are experiencing constant rape, constant infections, you know, who are living in poverties and dependent on men, and often with that relationship comes an HIV infection. And the silence of all of the circumstance around it. And what we have to be really focused on is the safe space for us to have the conversation, but the leadership of our faith communities in having that conversation. Not in quiet rooms that are safe, but in fact in public rooms that feel unsafe. And that we need that leadership of ministers and of other people of faith, just as in the early epidemic days where people like Bishop Tutu or Calvin Butts or, you know, and quite frankly, President Yosemite stepped out in public spaces as leaders that were uncomfortable. And to really, and we need, you know, in our HBCUs and others, because, you know, my view in this era, it's not sufficient to have a resistance movement. You have to have an agenda. You have to have an offensive game if you're really going to win the title. And so we can't just be talking about playing defense. We need to be talking about what does the world look like for us and how do we demand it and organize to achieve it, as we've done for 400 years. I mean, our freedom came even in slavery because there wasn't just a resistance to slavery, but there was an active campaign to undo it. And, you know, and Harriet in particular, if we really want to talk about the model, she didn't just run and get the freedom, but she went back time and time again. That's not just passive. That's an agenda. And what we need to be thinking about in our mobilization right now, particularly with the strength of our faith communities, that if we love black people wherever they are, as we're talking about the global epidemic and we're talking about the CBC and we're talking about our faith communities, how do those ministries in each of our individual churches, we've been working with an initiative, and one of the things that we found recently in working with the Black AIDS Institute is that our communities do a lot of work that remains hidden. And so there are very large systems, like when we're talking about the HIV epidemic, we know what the Catholic Church does. You know, the Catholic Church can tell you every single nun where she's stationed, every single priest, every single clinic that they're funded. That, you know, that directory is, and that data gathering is on point. The Anglicans can pretty much do the same thing. But, you know, Allen Temple may do this here, and another church across town maybe do this here. They don't often talk to each other. And somebody's sending a box of this over here and a box of that. All of that adds up to a lot. But we have got to organize and collect the data of what we do a little better, a lot better. And we also need to, on the ground, come together as more faith coalitions with a clearly articulated voice of what we want to achieve. Because I just want to end with this, this year we've done very well with funding. And with the leadership of Congress really revalidating all of what we're doing. And the prior panel may have mentioned it, and I want to talk about the intersection of that. But next year, we've got a really big congressional election year. And we already have a lot of resignations that have been announced. There are people who are not going to run again. All of that means institutional memory and commitment to HIV is walking out the door. And the new people, unless we are clearly articulating in their communities that this is a priority for us, it won't be part of their agenda. And so we need to be clearly, and when they hear it from our churches, when they hear it from our mosques and temples, when those people are running for office, and you're able to say, think about Nashville with both Dr. Hildreth and Reverend Sanders. If Senator Corker, who's been the chairman of Foreign Affairs and really a strong supporter of PEPFAR, decides not to run for re-election, that is a huge voice that is absent. But whoever that replacement is needs to know that part of their job is to continue the work of Senator Frist, of Senator Corker, and now it's part of their job to own that. But they're only going to hear it if our institutions are speaking up. So I hope that, I just want to throw those things out. We need to speak about what's creating the conditions of HIV more loudly. Particularly sexual abuse of young girls, and we need to organize better to tell the new members and the coming back members of how important our global response is, and the churches and all faith communities have a unique and powerful voice in being able to convey that.
And on that note, as Cornelius mentioned, we are engaged in doing research to identify faith-based efforts to address the AIDS, black faith-based efforts to address, say that 10 times backwards, to address the HIV/AIDS epidemic, particularly in the global space, especially in Africa. And if any of you have examples of work being done by faith-based organizations focusing in Africa, we're looking for those examples and those case studies that we can include. You can email me at philwilson@blackaids.org. That's PHILL Wilson@blackaids.org. You can go to the Black AIDS Institute's website, www.blackaids.org, or call our office if you have any examples of that kind of work. We are actively, aggressively trying to seek out those examples, to highlight those examples, to show the work that has been going on in black communities to address the global epidemic and to address the lie that we're not present, because we are present. We have been present all along in that regard.
And can I just add also that this year in Abidjan, Cote d'Ivoire, ICASA 2017, December 4th to the 9th is also a place. It's the All Africa HIV Conference, and Dr. Ron Simmons and I have been participating in the International Steering Committee work around that, but our goal is really about this bridging. The goal is about, how we as African Americans and Africans in the black diaspora are linking up and talking and collaborating across these systems, because it's us. And as Phil is saying, lots of people are doing lots of things. People do support people back home, and people do come over and go over, etc. We are encouraging as many people as possible to consider participating in ICASA, going to learn and engage with other black people about where we are in the epidemic and where we're headed. So just, look for the All Africa HIV Conference and consider joining some of the networks and conversations about that work.
And as Jesse reminded us, we can do more than one thing at a time. We can multitask. That's the nature of our survival. And so as we wrap up this panel talking about the role of faith in the global space, we also want you to not leave here and we wouldn't want you to leave here and forget about the fire that is burning across town as it impacts the domestic epidemic. And no matter where you live, no matter who your representative is, to call your representative, to call your member of the Senate, and to communicate to them how you feel about this bill that's coming up right now. And to let them know how that personally will impact you and what you expect them to do. And as is our tradition, we should have began with prayer, but it is never too late. And so we'd like to ask Reverend Sanders to deliver the last word of this session in an appropriate way in our tradition.
I very often will say to people that perhaps the most important prayers are prayers where it's heads up and eyes open. So I pray that as you look at each other, you will see in the face of those in which you look that the possibility and the potential is within us and among us. When we look at each other, we realize that all of us are the evidence of the way in which we were created, that has locked up within creation all of those things which we need in order to answer the questions that we're raising. When we look at each other, we can look at each other in a way that allows us to be able to see that the God in me and the God in you, connected together, can have a transformative effect upon the world. When we look at each other, we'll realize that no matter what our circumstance might be and what our experience might have been, that there's a way in which change is evident in everything about every faith tradition that we represent. When we look at each other, we see the answer. If we'll just allow our hearts to be open and our minds to be postured to receive that which has been imparted to us today. We've heard great wisdom that's been imparted to us. We've heard great stories of hope. We've felt and seen the pain of this disease. And now it's our responsibility to take the threads and weave them into a fabric that allows there to be a clear picture in terms of the direction we have to move in. That's our prayer. Amen.
Again, we want to thank Congresswoman Lee for her leadership on this. Particular thank you to Kiefer in the Congresswoman's office. Stand up, Kiefer. Yeah. And ViiV Healthcare for supporting this issue. So go out, make telephone calls, send emails, send faxes, send texts, do all of that. We need to find a victory this week. Thank you all very much.